88 or less, they qualify for oxygen. So we like to see them at least, especially if they have severe COPD, you know, in the 90s. Some of the patients can't maintain that, but that's why they need to have the oxygen. And what we're looking at to prevent is the tissue hypoxia and preserve the cellular oxygen. And one of the things I always tell patients is that the oxygen level, you know, it's there to protect the brain, their heart, and all of that, not just looking at a sat, but we want that oxygen to get down to the tissues. And if you don't have it there, you know, those other organs can, you know, get into a lot of trouble with and start having to work a lot harder. So and that's one of our goals, increasing the PaO2 to values a lot on a COPD or a lot greater than 60 adds very little benefit to that patient if their oxygen levels, you know, in their lungs are in really bad shape. And there is a risk of increasing their CO2 retention that can lead to respiratory acidosis. Some of the first line delivery methods, you know, when you have somebody come in, the first thing we're going to do usually is put them on a nasal cannula. You check your room air sats, so Linda has it for those patients that are coming in. It's real good to have a baseline room air before you ever put them on, so you know where you're at with those patients. The best thing is always nasal cannula. You know, if you have somebody that's on the lower side, it's quick, it's easy, they can talk to you easily, you're not, you know, impeding on the other things that you're doing. Then the other would be a venti mask. And I'm specifically talking about COPD. When you're giving oxygen, if you see simple masks that are out and around, and we've been trying to get the simple masks, they're off of 2,000 masks, thank goodness. But simple masks, to me, the only place that those are good for is if you have somebody that's in the recovery room that's waking up, they're, you know, mouth breathing a lot, they're not, you know, waking up all the way, they need to have a little bit of oxygen just to bring them up a little bit, then a simple mask is probably okay. You can throw it on, get a little oxygen to them. The problem with simple masks is when you don't know how to use them correctly, a mask can be dangerous in the wrong hands, that it's not being used with if you don't know how to run the flow with them. And that's why we keep wanting to do the education, because you need to have a flow of at least 6 liters. If you don't have a flow of 6 liters going through there, and that patient's minute volume is up there and they're breathing fast, that mask holds that CO2 in when they rebreathe, so they're rebreathing a lot of CO2. So if you only have a 2-liter mask on them, you're not flushing out the CO2 out of that mask, so their CO2 level will go up. Then you can get a little CO2 build up in them, and they get really sleepy, and it's not a good thing. So that's why I don't like simple masks on the floors. If I have a patient that needs to have oxygen, I want to know what oxygen it takes to get them where they're at, not a guesstimation. I want to, you know, if it's a patient that's getting worse, I want to know that it takes 40% to get them where they're at, or 50%. And those are those, once they're starting to get a little worse, that's where you need to know 50% oxygen with a venti mask, and these are our venti masks that we have. If 50% isn't maintaining them, I want to know that 50% of oxygen isn't maintaining them, and I want to know how much oxygen it's going to take to maintain them, because past this, I've got to go to other devices here. And we do have the rebreather mask, which I'll get into. That's the second line. We have the non-rebreather. The masks that we don't really have partial rebreathers here, but this one can be made into a partial rebreather. This mask is kind of designed for a little safety. It is a non-rebreather, but if you notice, it's got one valve off. If I put this mask on a patient and don't have enough flow going through it, if I put this on with 2 liters, there's a valve here in the very top and the valve on the side. If this one had the valve here, what did I do? Oh, uh-oh. I shouldn't hold that in my hand. If I and that patient takes in a breath and there's only 2 liters of flow going through here, they can't pull in any more flow. This bag has to be deflated. So they're pulling in and they're not getting the air or the oxygen they need. With having the one valve off, it lets them entrain a little bit of oxygen in, but not a whole lot, that they can still, room air to get in. So 2 liters might be okay to keep their PO2 up and their SAT up, but you may have just put their CO2 up into the 80s. So that's why, these masks need to be 8 liters or above. What you need to do, and the more the better, this bag should always be inflated when you're using it. You just hold it down, the bag will inflate, and as long as that bag is staying inflated, you should be okay. You get a patient that's having Kussmaul respirations, they can deflate one of these bags very easy. So you'll see them go, and they're breathing in. So you want enough flow to keep that bag from deflating. You can make these a partial and get a little less oxygen by taking the valves out. Then it becomes a partial rebreather. You get we'll go more in that, but with your basic nasal cannula, and usually use that flow from 1 to 6 liters. You can go a half liter. Some patients we've had to really wean down very gently, and just a little bit has taken them down. There's no real standard rule to say, well, if I'm on 2 liters, what if am I giving that patient? They have a little formula that you can take 20% plus 4 times the O2 liter flow, and you can kind of say it's in a range of 6 liters might give you 35 to 40%, but you don't know, because what the factors are that change that is how fast they're breathing, how big their tidal volume is, or how deep of a breath they're taking, and just all the things that are going on in their lungs. So you just don't know what FiO2 you're given. So we watch the SATs and try to keep them at 92 or above. If the patient breathes slower, you get more flow into the nose, and it kind of builds up there. So when they take a breath in, they kind of get a little bit more oxygen in. This is the Venti mask, and ours will go up to 50%. So you can get from about, I think it's 23 or 24% up to 50. But what these do, if you bring back college days, Venturi principle, does that ring a bell? When you have a flow going through and you have the air flow going through in the center, and it will pull in air from the outside, and that's what it's doing. It's pulling in the air from the outside along with it. We'll end up changing that, you get that air that's pulling up through it, and then when that happens, you're pulling in room air. When you're pulling in the room air, it will make a precise amount of oxygen. So this will tell me how many liters to put it on, and it will pull in to make a higher liter flow. So even though I may only have this on 3 or 4 liters, the liter flow that I'm putting out is a lot higher, because I'm actually using that Venturi principle and pulling in the oxygen. So this one can meet their demand needs that the patient needs, that some of the other things can't. You put a simple mask at 4 liters, their SAT's okay, but their CO2 can go up. So that's why this, is your best choice. You know what you're given, you know what it takes to do it. You have to do a gas, you can say patient's on 50%, the gas is bad or the gas is good. If it's bad on 50%, something else has got to be done. and this was the non-rebreather. It's, it says that the FiO2, 60 to 90%. And we say sometimes, you know, if you had both valves on these, you can say you're gonna get 90%, you don't. You know, probably the most that you're gonna get is about 75%, but most of the time when you're doing this, those patients are breathing fast and shallow. So you're, you know, they will give high concentrations of oxygen, but it's still not probably what you need. So you just need to know these have, you know, they're good for if you need it and to give the O2 now, but they do have their restrictions on how much you're actually going to give. And if you don't put enough flow on there, what happens to the CO2? Goes up. There are devices out there. We don't have any here. We've talked about them and I think a couple other things. And it's high flow heated humidity oxygen. And if we ever could get to the place where we could have a couple of these for some of these patients that are coming in that we can't keep, you know, they're really bad, their respiratory rates are high, you know, you're not getting ventilation through, they need treatments and nothing's ventilating, you know, they have a big VQ mismatch. These, you can put up to 40 liters with a nasal cannula on a patient. Now, if you put 40 liters cannula on a patient off the wall, you're going to cause barrel trauma to the nose, and you know, trauma to the nose. It's a lot of turbulent flow, and you just can't do it. But you heat and humidify oxygen and put that to them. It's amazing what you can do with that kind of oxygen. But hopefully someday, you never know, we might be able to do it. And there are ways that you can do it with. Without having the actual vapotherms, you can actually do it with heated Fisher-Paykel's or something and run it up. But that's always an option that's hopefully someday that we might be able to use for some of the patients. Then you get the acute, an acute increase in the FiO2 can cause a ventilation perfusion mismatch and lead to hypocapnia. And so it's recommended that you just get your flow going so that you have your PO2 to be above 60 and or a SAT of 90 in that COPD patient. Because if you get it up too high, vasoconstriction, all that going on in the body can actually make them ventilate or perfuse places in the lungs that are not being ventilated as well, and the places that are being ventilated as well aren't being perfused with the blood they need. So that's where you get the VQ mismatch, and you need to then you'll start seeing that CO2 retention. This alveolar hypoxia leads to pulmonary artery vasoconstriction, which causes increased blood perfusion to the underventilated areas of the lung. And as you better ventilate that patient, the way you're going to do it, you're going to improve that ventilation perfusion. And how we're going to do that is, if you have somebody that's getting worse, as Dr. Roche has said, is by using the BiPAP. You want to watch for your CO2s. If you have a patient that has a CO2 in the 40, you know, in that 45, 50 range, and their pH is normal, and they're breathing kind of normal, you know, they probably live there. If you have a patient that's breathing 38 times a minute, and their CO2 is 60, and their pH is, you know, 7.3, you know, those are red flags. And that's why I like to, you know, get that base gas to see where your pH is, to see if they're compensating or not. They can compensate for a while, and that CO2 still not be high. And if, you know, if their pH is